The purpose of this presentation is to educate fellow nurses on the signs and symptoms of two diagnoses related to the hormone called antidiuretic hormone. These disorders are called diabetes insipidus and the syndrome of inappropriate antidiuretic hormone. Before diving into these disorders, it is crucial to understand the role of antidiuretic hormone. It may seem minimal, but the role of ADH is very important to fluid balance. It regulates fluid balance by controlling the amount of water reabsorbed by the kidneys while they are filtering waste out of the blood. Diabetes insipidus, or DI, is far different than diabetes mellitus. The underlying root of DI is inadequate excretion of antidiuretic hormone. This decreased ADH production causes fluid to not be absorbed in the tubules of the kidneys. The fluid is then excreted as urine instead of being used within the body. This disorder impacts several body systems, but most significantly the cardiac and renal systems. There are two main types of DI. The first is called central diabetes insipidus, and it's caused by trauma or surgical procedures affecting the pituitary gland or the hypothalamus.
In diabetes insipidus, patients experience profound diuresis, often as much as 3 to 20 liters in a 24-hour period, which leads to deficient fluid volume, manifesting as tachycardia, hypotension, weight loss, constipation, and poor skin turgor. Polydipsia, weakness, and restlessness are signs of hypernatremia secondary to deficient fluid volume. If left untreated, the patient will eventually go into shock, potentially causing irreversible damage to the central nervous system, or even death. The easiest way to diagnose DI is through a water deprivation test. In a healthy person, a reduction in fluid intake will result in urine output that is decreased and more highly concentrated. In someone with DI, a decrease in fluid intake will have little to no effect on output, but will cause weight loss from dehydration. Strict intake and output monitoring is required to ensure that this test is accurate, along with frequent weight checks. The provider will also check urine and plasma osmolality and urine-specific gravity. Fluid replacement therapy for DI is crucial. Oral intake is encouraged, but IV replacement can be supplemented as necessary. Electrolyte levels are checked frequently to avoid imbalances during treatment. The most common treatment for DI is desmopressin acetate as a synthetic replacement for antidiuretic hormone. Assessment of the patient's fluid balance will be performed through hourly INOs and daily weights.
DI treatment and medications. Preventing dehydration is the most important way to manage diabetes insipidus. This can be promoted by increasing fluid intake and avoiding activities that cause dehydration. A low salt and low protein diet may also be prescribed to help decrease urine output. Antidiuretics and desmopressin are also the drugs of choice to treat diabetes insipidus. The main goal of treatment is to decrease the amount of fluids lost while maintaining balanced electrolyte values. DI patient education. Follow-up appointments are very important for DI patients, so therapy and medication can be adjusted as needed and treatment can be effective. Patients should be educated to weigh themselves daily to monitor for weight loss, which means the body is not retaining enough fluids. Education should also be given to decrease sodium intake and increase their water intake to prevent dehydration from the polyuria they experience.
The syndrome of inappropriate antidiuretic hormone is the opposite of diabetes insipidus. SIADH is caused by excessive antidiuretic hormone, leading to fluid retention. With the increase in ADH, the renal tubules become more permeable to water, just opposite of DI, where the renal tubules become less permeable to water. It causes increased water reabsorption, basically flushing out all of the osmolar sodium, and this leads to a variety of symptoms. There are several factors that lead to SIADH. Several types of medications can cause it, including medications for regular diabetes, anticonvulsants, antidepressants, cardiac and blood pressure medications, and some medications for cancer. General anesthesia during surgery can cause SIADH, and injury and infections of the brain, including stroke, can lead to SIADH. Additionally, lung diseases like pneumonia, TB, cancer, or chronic infections can cause SIADH. There are also a few rare causes of SIADH, including disorders of the hypothalamus and pituitary glands, some rare cancers, and some mental health conditions.
Hyponatremia from excess fluid retention causes a slew of issues in SIADH. These can include level of consciousness changes like confusion and disorientation, and sometimes even loss of consciousness or seizures. Anorexia, nausea, and vomiting are also common symptoms. But despite the lack of nutrition, weight gain is a frequent manifestation due to excess fluid volume. Patients with SIADH often look plump and healthy, but in reality, they are typically malnourished and extremely ill. SIADH is diagnosed when serum osmolality is below normal level and urine osmolality is above normal. These values indicate the inappropriate excretion of concentrated urine in the presence of a dilute serum. Other laboratory tests to support an SIADH diagnosis include a decrease in blood urea nitrogen, hemoglobin, hematocrit, and creatinine clearance secondary to hemodilution and elevated urine sodium.
SIADH treatment and medications. The first line of treatment for SIADH is to limit fluid intake to avoid further buildup. Hypertonic saline is also given to manage the hyponatremia that accompanies this disorder. Medications may include those that can reduce fluid retention, such as diuretics like Lasix, and those that can inhibit ADH like demeclocycline. Surgery may also be a treatment if the disorder is caused by a tumor producing excessive ADH in the body. SIADH nursing interventions. Some of the nursing priorities for SIADH include monitoring fluid intake and urine output to accurately measure these levels and make sure the fluid restriction order is being understood and followed by the patient. Daily weights are also a priority, not only so the patient can monitor their goals, but also to ensure weight gain caused by excessive fluids isn't occurring. Restricting fluids and replacing sodium is also a nursing priority so that the patient's daily water intake is lower than their daily water losses. Monitoring for fluid volume excess will show whether or not treatment has been effective. SIADH patient education. Patients with SIADH should be educated to increase sodium intake, limit intake of water, get sodium levels checked, and take medications as prescribed. Limiting intake of fluids that contain mostly water as well as increasing sodium intake will help the body not retain so much water and replenish the sodium loss that this disorder causes. It is also very important to get sodium levels checked regularly, take medications as prescribed, and go to all your follow-up appointments so that the doctor can monitor if the therapy has been effective.
While TikTok can be sometimes not very credible and kind of a time suck, we found these two really great videos that explain the differences between SIADH and DI. Hopefully you guys can use these as study tools for our upcoming exams and for the NCLEX as well.
This is a two-part series on SIADH and DI. So for SIADH, we think C, like Spanish for yes, ADH, adding H2O. We will see these characteristics. 1, we stop urinating, which causes sticky and thick urine, most commonly seen with high specific gravity. We're also swollen inside. Because we have too much ADH in the body and our cells become diluted, we experience hypoosmolality and hyponatremia. Again, low sodium, and the key finding is headaches as an early sign. Swelling causes increased pressure in the brain, and that puts the patient at risk for seizures. Key signs are headache and confusion. Remember that. Severe high blood pressure because we stop urinating and we're swelling, so we're going to stop all fluids. Give salt because salt and water are best friends, and diuretics. Now for treatment. For SIADH, we want to get rid of that excess body water. We're going to stop fluids, monitor eyes and nose, measure daily weight, and give salt and diuretics. The key here is to maintain homeostasis.
Let's talk about diabetes insipidus. This is also referred to as DI. In diabetes insipidus, we don't have enough ADH. Well, what is ADH? ADH is also called anti-diuretic hormone, and it's found in the pituitary gland in your brain. You can remember the function of ADH by thinking ADH adds H2O to the body, aka anti-diuresing effect. It holds onto water in the body and doesn't excrete it in the potty. So in diabetes insipidus, we don't have enough ADH, which means we do the opposite of adding H2O. We are losing H2O, aka peeing a lot. DI, think dry inside. We're dehydrated, we have fluid volume deficit, which leads to shock, which is never a good thing. So for the signs of DI, again, think dry and dehydrated. So we're gonna see these signs and symptoms. That's all for diabetes insipidus. For more nursing help, check out my complete nursing school bundle on my Etsy shop. It has all the nursing school subjects to help you pass nursing school and make nursing school a bit more manageable.